Hello students, today we will be talking about anti-diabetic drugs part 4. We will discuss a novel anti-diabetic agents, that is GLP-1 agonists or GLP-1 analogs. They are also known as incretin mimetics. In next slide we will see what are incretins. What are incretins? What is the source of incretins? What is incretin effect? What is the therapeutic significance of incretins? What are incretin mimetics? First of all, the term GLP-1 agonists refers to group of medications that mimic a hormone in the body known as GLP-1. Now, incretins, the source of incretins is from GIT, the endocrine potassium cells in the upper GIT, that is duodenum and jejunum, and L cells in the distal part of gut, that is ileum and colon, produce and secrete two important gut hormones, that is GIP and GLP-1 respectively, into the circulation. GLP-1 is also found in the brain, especially nucleus of the NST tract and hypothalamus. But both these hormones can cross blood-brain barrier. Now, GLP-1 means glucagon-like peptide and GIP means glucose-dependent insulinotropic polypeptide. These are incretins. So we have understood what are incretins, what is the source of incretins. Next is incretin effect. This very effect was first of all proposed by Roosevelt in 1970. They made a very important experimental observation that insulin secretion was 2 to 3 times higher after oral glucose intake than that after intravenous glucose administration. We can further clarify it when we administer insulin by intravenous route. No doubt it will activate pancreas to release insulin, and that very insulin is responsible for uptake of glucose inside the cell. At the same time, when same glucose is administered by oral route, it will enter into the gut. Again, it is going to activate the beta cells of pancreas to release insulin. So there will be no doubt a fall in glucose concentration in the blood, but at the same time what we observe is the secretion of insulin via oral route is more as compared to that administered by intravenous route. The reason is that when we administer glucose by oral route, it also takes up hormones released from the gut, that is incretins. So incretins have a tendency to make pancreas to release more and more insulin. This was the observation made in 1970. This is known as incretin effect. So here what happens is GLP-1, it acts on GLP receptor found on the beta cells of pancreas, and this very receptor is basically G-coupled protein receptor, and it has got alpha unit, it has a beta unit, it has a gamma unit. What happens is alpha unit is bound to GDP. When it is activated, what happens is GDP gets converted to GTP and alpha unit is released from this complex. It activates a very important enzymes in the cell membrane, adenyl cyclase AC, that further releases ATP and amounts to release of cyclic AMP. Cyclic AMP, after entering into various cellular events, stimulates the release of insulin. This is the mechanism of action of GLP-1. So what researchers have found that why not have drugs which could mimic the action of GLP-1, glucagon-like peptide. So they are known as glucagon-like peptide agonists or analogs or incretin-mimetics, because ultimately GLP-1 agonists would release incretins. Incretins would tend to release more and more insulin. So GLP-1 drugs, as I said, GLP-1 agonists or incretin mimetics are the target for diabetes, to treat diabetes. They have number of therapeutic implications. They support weight loss by mimicking GLP-1 hormone. They increase insulin secretion. They suppress glucagon release because action of glucagon is opposed to that of insulin. They slow gastric emptying. They reduce appetite. So that amounts to weight loss. These effects lead to decreased caloric intake, improved satiety for type 2 diabetes mellitus, improved blood sugar levels. Some of the important examples of GLP-1 agonists are liraglutide, exenatide, dulaglutide, semaglutide, albiglutide. So there is a lot of difference between GLP-1 agonists and metformin. Metformin does not release insulin secretion. It is simply an insulin sensitizer. Metformin does not slow down gastric emptying. On the contrary, GLP-1 agonists, they tend to release insulin more and more due to incretin effect because they are incretin mimetics. GLP-1 agonists cause slow down gastric emptying. Next is, if we compare them with sulfonylureas, most prominent side effect with sulfonylureas is they lead to hypoglycemia. This tendency is very less with GLP-1 agonists. In addition to their benefits, they have a beneficial effect on heart and kidneys also. They are effective in promoting weight loss. They have better kidney and heart protection. As we said, to summarize it, they stimulate insulin secretion, they reduce glucagon secretion, they slow down gastric emptying, they reduce appetite. And lastly, the possible dose of axanide and dosage forms is 5 mcg dose, 1 to 2 ml per pun. They are given by IV route. Liraglutide, these are the dosage forms. Multi-dose pen is the device with the help of which it can be administered. Thank you.